Uh, I think we should start. We still have participants joining us, but we can start right about now because we're already 3 minutes ahead on our schedule. Good morning, good afternoon, and good evening, everyone, because I know we have a lot of participants joining us today from all over the world. Welcome. Welcome to this webinar. This is a webinar that's organized by the International Institute for Primary Healthcare in Ethiopia in collaboration with Johns Hopkins Bloomberg School of Public Health. And this is the very first webinar from our tripartite series that we have organized regarding urban primary health care. And this webinar revolves around the characteristics of community health workers in urban primary health care program. So this is the first thematic area that we will be discussing. Please feel free to introduce yourself. You can let us know who you are, where you're from in the chat box, and then you can say hello to everyone. On behalf of the Institute, I would like to welcome everyone to this webinar. And we will be having, panelists with us for the first series from different contexts, from different settings, and they will be sharing their experience and expertise in urban primary healthcare, especially in terms of characteristics of community health workers. And after that, we will have an opportunity to have discussion, comments, and question, and then we will wrap up our session. We will have about an hour and a half for this entire session. So before I introduce our panelists, I would like to welcome Dr. Rajani Ved from Johns Hopkins Bloomberg School of Public Health. She has been supporting the Institute to organize and design this webinar series. So she will be briefing us or giving us a highlight about this webinar series. So over to you, Dr. Rajani.
Thank you very much, Dr. Fraywat, and a very warm welcome to all of you attending this webinar. This is the first of a tripartite webinar series, and each of them is scheduled for the last Thursday of today, July and August. Why this series of webinars now? Nearly 55% of the world's population today lives in urban areas. This trend is expected to continue, and by 2050, with the urban population more than doubling its current size, nearly 7 out of 10 people in this world will live in cities. Addressing the health needs of the urban poor is a complex issue, as we will hear from the speakers today and from the next two webinars. Most low and middle income countries have a very long-standing focus on rural areas. Our collective knowledge, expertise, and experience in designing health services in rural contexts at community and facility levels far outweighs an understanding of developing accessible and equitable health services in urban areas. The current organization of services in urban areas, especially primary healthcare services, is not as well structured as in rural areas. Partly, this is a function of growing informal settlements in urban areas, increasing population density, and making it difficult for health workers to enumerate and register populations in need of services and planning for service delivery, especially for vulnerable populations. There is also a multiplicity of providers, government, private sector, healthcare facilities, and NGO service providers. But notwithstanding the pluralistic health systems in many cities, public health is still a function of government, and yet government primary healthcare services in urban areas are not equipped to meet complex and evolving urban health needs. COVID-19 showed us clearly and tragically the problem with the lack of integration of public health functions into primary health care, resulting in a less than optimal response to surveillance and tracking and management overall during the pandemic, affecting not just the urban poor, but all urban populations. Dealing with the complexity and diversity of urban areas requires us to move away from conventional sectoral approaches that are based on biomedical health models to undertaking coordinated action, taking into account ecological interpretations of health, including the social dimensions. Uh, our hope for this webinar series then is to bring together learnings and best practices in urban primary healthcare service delivery from a variety of contexts in low and middle income countries. This first webinar is focused on community health workers in urban areas. The second webinar in July deals with issues of service delivery, organization, and management to meet the needs of primary healthcare and essential public health functions. And our final one in August is on the structure and process of urban local governance on addressing cross-sectoral convergence and influence on primary healthcare. The objective of our webinar series, and I hope you'll walk the journey with us, is to enable an improved understanding of urban primary health challenges, identify opportunities for cross-learning and sharing, looking at priorities for research, capacity building needs and innovations, and generally building a community of practice for improved population level outcomes for urban primary health care. I hope you all have an enjoyable learning experience today and hope you're able to join us for the other two webinars and stay engaged with the agenda going forward. Thank you, Dr. Fraywat. Over to you.
Thank you so much, Dr. Rajani. For the interest of time, I would go ahead and introduce our panelists. We have three panelists today here with us. Our first panelist is from Bangladesh. Her name is Dr. Morshida Chowdhury. She is from BRAC, and she is currently the Director of Health and Nutrition and Population Program there. She is also she oversees around 21 projects there, and she is currently leading the responses to COVID-19 at BRAC at the moment, and she'll be sharing with us her experience from Bangladesh in terms of the characteristics of community health workers engagement. And our second panelist is Dr. Mirgesa Kaba. He is from Ethiopia. He is an assistant professor at Addis Ababa University, and he is also the lead for Horn One Health Project, which is supported by University of Liverpool. He has served in different universities, well-known universities in Ethiopia in the past. And he has also a very rich experience in teaching, research, and in community engagement. Our last presenter is Miss Dennis Octavia Smith. She is from the United States of America. She is the founder and executive director of National Association of Community Health Workers there. She's also a visiting scholar at Harvard University School of Public Health, and she has an experience, especially her being a community health worker. She has a dense experience in supporting such endeavors, especially national initiatives to advance the engagement of community health workers there. So we're gonna start our discussion. We're gonna start our presentation with Bangladesh and then proceed to Ethiopia and finally hear the presentation from USA, and we will have a discussion session after we wrap up all the presentations from our panelists. So I'm gonna start with our first panelist, Dr. Morshida, over to you.
Thank you, Freyot, and welcome others who have joined us today. And thank you for having me and give me the opportunity to share our experience in urban healthcare program in Bangladesh. So let me pull up my slides. All right, where is it? Okay, got it. Is it visible?
Yes.
All right. Okay, let me go through the slideshow or full screen I can't go to the full screen mode. Where is it? I'm not used to it, I guess.
Right next to, yeah, before that, yeah.
Here?
Yeah.
Okay, I guess I got it. Yeah.
Yeah, you're right. You got it.
Yeah. So, yeah, is it visible now? Got it.
Yes.
All right. So today, I would like to share our experience as well as, but I'm going to more focus mostly the challenges and lessons we have learned from the activities we are doing in Bangladesh. So the outline of my presentation would be, I'll give a brief context, urban context in Bangladesh at first, that where in which context we are operating in, and then I will talk about briefly about the healthcare system in urban areas, and then BRAC's experience in addressing the gaps in urban health system, especially to address the gaps for the poor. In Bangladesh, Bangladesh is going through a rapid epidemiological, demographic, and social changes. And in terms of demographic change, the population is now mostly younger group, and also elderly group is also increasing. So their disease pattern, their health demand is also changing. It's not like it was 10 years ago. And according to the epidemiologist, the disease pattern also have changed a lot. In 10 years ago, where we had been suffering from communicable diseases, and now there is a high burden of non-communicable diseases on top of communicable diseases. At the same time, we are suffering from the triple burden of malnutrition, that is undernutrition, overnutrition, and also micronutrient deficiency. And we are also going through a rapid urbanization, with the rate is like 6% a year. In some places, it's more than that. And currently 27% people lives in urban areas, and the population growth in urban areas is double than in rural areas, which is mostly due to migration from rural areas due to climate change, climate migration mostly, and also due to loss of jobs in rural areas for various reasons. And biggest city, Dhaka, the capital city, which is a mega city, is alone hosting 40% of the urban population. So our population, urban population, is hugely suffering from non-communicable diseases, mostly due to this rapid industrialization, rising income, unhealthy lifestyles. Nutrition is a problem everywhere, but this is the, one of the major problem in urban slums if we compare it to even to rural areas. As I told before, that the rapid influx of rural population into the urban areas, creating a pressure on the health system, which is not ready to cater this extra population which are accumulating in the urban settlements, especially in slums and floating everywhere. So in urban areas, Ministry of Local Government, Rural Development, and Cooperatives are responsible for providing primary healthcare services. Whereas if in contrast, if I compare it to the rural areas, in rural areas, primary, secondary, and tertiary, all 3 layers of services are being provided by Ministry of Health and Family Welfare. Whereas in urban areas, the local Ministry of Local Government provides the primary services, primary care services, and Ministry of Health and Family Welfare provides the secondary and tertiary healthcare services. So, and also the Ministry of Local Government is suffering from resources, like lack of resources. As a result, the private sector is proliferating rapidly, and they are basically providing curative care, which is more profitable and unregulated, and they have least attention for preventive and promotional healthcare services. In urban primary healthcare system, if I talk about it a little bit briefly, the Ministry of Local Government provide this with like multiple NGOs through city corporations, and the number of there are 361 static centers and 4,000 satellite centers and 35 urban dispensaries. This caters this whole huge number of urban population, and they mostly focus on family planning, immunization, maternal and child health services, and also currently they have added NCD. And as I told you that this is hugely these services are largely inadequate for this fastest growing population, and there is no there is a functional linkage with Ministry of Family Welfare and Ministry of Local Government. As a result, there is no referral linkage with primary to secondary and tertiary level facilities. So this coordination is giving rise to many caveats where many private providers are operating illegally or exploiting urban force. BRAC's approach, in terms of BRAC's approach in mitigating these gaps in urban primary health care, we are doing many activities. So I will be talking about today and especially targeted intervention for urban subdwellers. So we have the largest community health worker network in Bangladesh. And this is a network of 50,000 health workers and volunteers across Bangladesh. And in urban areas, we have launched the intervention in 2007 with financial aid from Bill and Melinda Gates Foundation, which ended in 2012. And the name of the project was Manushi, and the aim of the project was to improve maternal, newborn, and child health status in urban slums. The project covered 7 million population in urban slums in 10 city corporation areas. And the services we have offered with for 4,500 trained community health workers in 2,000 slums. In Bangladesh, there are like more than 2,000 slums, but we are covering 2,000 slums. And we have also established 41 birthing facilities, or we call it maternity centers. So the services we offer is mostly doorstep services with community health workers, and the services are basically health and nutrition education, family planning counseling, treatment of common ailments, basic antenatal and postnatal care, screening for NCDs, and referral services. On top of that, through maternity centers, we also provide safe delivery care services to pregnant women, and also prenatal and postnatal care, and other and also child health care services. In coordination with the Director General of Family Planning and City Corporation, we offer family planning services, mostly long-acting family planning methods, and also immunization program from maternity centers as well. And we have established a functional referral linkage with some public and private higher level facilities to refer those mothers who have complications around childbirth or also neonatal problem. So the major vehicle of our service is community health workers. So how we define community health worker, that's the definition of the she should be a resident of the community, and she should be either assigned by government or a non-government organization, and she will provide preventive, promotive, and some basic curative and rehabilitative care services, and she should be accountable to the community. The name of our community health workers are Shastu Shebika and Shastu Kormi, but we have many other cadres, but the numbers are low. So today I'll be talking about only 2 cadres who are majority in numbers. So Shastu Shebika, our program has been launched in 1990s, but if I go back, BRAC has started this intervention in 1972, just after liberation, and BRAC has piloted or I would say practiced and tested many models, and many models failed. And then finally we got the Shastu Shebika model. So we started with clinics staffed by doctors. We tried with paramedics. We tried with male-female paramedics, but all failed to serve the rural population and hard-to-reach population who basically needs this preventive and promotive care. But finally, we found a model, the Shastu Shebika, who is a person who is selected from the community, especially from the microfinance group of BRAC, which is known as village organization, and she was able to serve the population, and because she has the connection with the community and she understands the problem, and she was pro-poor, and her the connection with the community was appropriately maintained, that we have opted for. So the characteristics of the Shastu Shebika was that she's little bit aged because of their characteristics. As I told you, that they have been still they are village women, they are microfinance board members, and their educational qualification was 8 years of schooling. So after selecting them, we provide them 2 to 4 weeks of training, and then they keep undergoing quarterly refresher training. So this is not one-shot training. The training is an ongoing process for all sort of community health workers. And their working hour is not fixed, because they are volunteer. We don't pay them. They are entrepreneur. After finishing training, we provide a package of commodities to them, including some medicines and health commodities. So through selling those commodities and medicines, and also to providing other services, they earn some money and make some money, and the amount is around $25 a month. So they basically this entrepreneurship model make them sustainable over the years, and their acceptability in the community has usually increases as their portfolio of services increases over time. So basically, they provide the treatment of diarrhea, pneumonia, the common ailments, fever, cough and cold. They also provide vitamins for deficiencies, provide family planning methods like pills and condoms, and provide safe delivery kits. They also assess, checks refractive errors, and provide reading glasses to women and people who are like more than 35 years of age. They have some special duties as well, and through which they also receive some performance-based incentive. One is that they identify pregnant women from the community, because they visit all their 500 households once in a month, and they talk about family planning method, and who gets pregnant. That is easier for them to track down. And they ensure adherence to TB treatment. But before that, they also identify ththose who are having cough for more than 2 weeks and then refer to the higher level staff where and also collect cough from them, and then if they are tested positive, then they also ensure the compliance with the treatment. They also refer individuals for health facilities, and for that they get some incentives as well. They have been supervised by Shastokormi, the higher level worker. Our research shows that their attrition rate is 10 to 15% a year. The next cadre is Shastokormi, and the Shastokormi is basically provides higher level of clinical care. This program has started from 2005 to support Shasto Shebikas and the demands generated to fulfill the demands generated by Shasto Shebika that they provide those services to the community. Their qualification is also 10 more than Shasto Shebika. It's also 10 years of schooling or a secondary school certificate. They also receive 3 to 4 weeks training, but this is more clinical training, as I mentioned before. And they receive monthly refresher training in contrast to quarterly training. And one Shastokormi supervises 10 Shasto Shebika, and they basically provide service basic antenatal and postnatal care to pregnant and new mothers. They screen for NCDs like diabetes and hypertension, and also checks for eye problem. They provide infant and young child feeding practices, and also both monitoring and services for under 5 children. They educate adolescent girls and women of reproductive age on various health and nutrition issues. We provide them a salary, and that is $50 a month. And on top of that, they also receive some performance-based incentive. Their attrition rate is 5 to 10% a year. This is a brief summary. This is a brief video. It's only 2 minutes video. If you allow me, I can show you on the project. Is it okay?
Yes, please go ahead.
Oops, sorry, why it's not playing.
যখন বাচ্চা প্রসব ব্যথা শুরু হয় তখন ডাক্তার আনে নাই, নার্স গ্রামের দাত্রী দিয়ে কাজ করাইছে। এতে অনেক সমস্যা হয়েছে, বাচ্চারা সমস্যা হয়েছে, মারা সমস্যা হয়েছে। এই এলাকার মধ্যে 90% লোকে মানে ব্রাকের মা। আমি তো শুরু থেকে ব্রাকে নাম দিয়েছি, কাট করছি। ব্রাক থেকে আপারা আমার অনেক সেবা যত্ন নেয়। প্রত্যেক মাসে মাসে আমি ওইখানে যাই, চেক আপ করি। আমার যাইতে দেরি হলে ওনারা আমার বাসায় এসে চেক আপ করে যায়, আমার দেখে যায়।
একটা মা এত কষ্ট করতেছে, তারপর যখন তাকে ডেলিভারি করানোর পর তার বেবিটা তার কাছে দেয়, তখন যে হাসে, অনেক ভালো লাগে যে একটা মা এত কষ্ট করে তাকে আমি হেল্প করতে পারছি। সবচেয়ে ভালো লাগে কি যে এই ব্যথার সময় তাকে আমি সাহস দিতে পারছি যে বাবা আমি তোমার পাশে আছি, তোমার কিছু হবে না।
So I hope you have you got the audio right. Okay. So can you hear me?
Yes, yes, we can hear you, Dr. Murshid.
Okay, sorry. So what we have achieved so far through this intervention, because this is this is reflected in the national health achievement as well. From 1990 to 2015, there has been a massive improvement in health and family planning and nutrition and other indicators. So if I just give you some glimpse that contraceptive prevalence rate increased from 5% in which was in 1976, 5%, that it was increased to 31% in 1991. But the story behind this was that that was even impossible in a country, conservative country like Bangladesh, when people were so resistant about family planning. At that time, government involved the NGOs, and I can talk about what BRAC has done. BRAC has incorporated family planning education in its functional literacy program for adults. So where it has talked about that why small family is needed. BRAC didn't talk largely about the importance of taking contraceptives, but importance of having small family. And then they understood that why small family is needed, and they voluntarily went for to have this family planning methods. So that is how BRAC helped government in achieving these contraceptives acceptance rates that high. Our maternal mortality also decreased by 71%. And maternal mortality mainly was stagnant in mainly rural and in slum areas. So if though these two places are addressed properly, so that could reduce maternal mortality, and it's now stagnant at some point though, but we have to push up a bit harder to bring it down, because we have picked all the low-hanging fruits. DPT vaccination, the same thing, the same success story. In terms of reduction of maternal neonatal mortality, it is the story behind it is that home delivery was very high in Bangladesh, which has been reduced by involvement of all parties like government and also NGOs. If I give you just example, in 2007, when we started Manushi program, 85% of the delivery was home deliveries, and now only 7% deliveries are taking place at home. So that means if we can engage properly, and this achievement was done within 5 years. It's not that we have achieved it now. So this could be done if we can engage the community health workers. I would not, in terms of child and infant under 5 mortality, there is another success story regarding the promotion of oral dehydration saline, where where the community health worker and women worker, they reached all 12 million households and teach every mother regarding how to make oral dehydration saline at home indigenously. So that was the success story, like globally known, I guess. So what are the challenges? So challenges in urban slum, urban space is that to engage the community, because everyone is working, mostly the women and the slum dwellers, they are involved with either domestic, they are domestic workers or garment workers. So it's very difficult to find them at daytime, and also space in the slum areas is very difficult to manage, to talk to them in very tiny areas. And conflicting working hours, as I told you that men and women both work at daytime, and so sometimes we have to manage to connect with them either through mobile or at the evening for some services. This population is highly mobile, and they move from one slum to another slum, it's very difficult to track them down, especially when they're pregnant and lactating, having under 5 children. And also integration of community health workers with formal health system, because the primary healthcare system is non-existent and it's operated by other NGOs, so it's very difficult to establish that linkage. And people usually don't like to adhere to the referral compliance, as the treatment in secondary and tertiary level facilities are troublesome, especially for public places, and costly in private places. And there is a strong competition in with the village doctors, pharmacies, the unregulated pluralistic private sectors. So so operating in that is a really unhealthy practice going on there. And sustaining a program with continued financing is really, and now is a problem for, I guess, everyone in developing countries. So what lessons we have learned so far? So we have the lessons we have learned that community health worker can be engaged with the community and can earn their trust and confidence, and provide services with confidence. And when community health workers are well trained and they have properly supported under good supervision system, they can perform in a complex situation like urban slums. A digital MIS can track down all the beneficiaries who are moving from different places, and right now we have developed this digital tracking system. A provision of technologies in providing services, especially during emergencies, like during COVID period, we have teleconsultation services that is really helpful, and it's also it also helps in performance management, feedback mechanism, to enhance their skills and knowledge of the community health workers through remote communication and also remote trainings. And performance-based incentive helps them to motivate and enhance their performance as well. And we have to link them with functional facilities for critical care when it is needed. And all our maternity centers are connected with different private and public facilities, and which is this is very important for community health workers to make right decision at right time. And social recognition of the health workers and family support is instrumental for them as well. So this is a small, very small video of our health worker, that how pleasure.
আমি গত 12 বছর ধরে ব্র্যাকের সাথে স্বাস্থ্যসেবিকা হিসেবে কাজ করছি। আমার 13 বছর বয়সে বিয়ে হয়েছে। বিয়ে হওয়ার সাথে সাথে 1 বছরের মধ্যে আমার মেয়েটা হয়ে গেছে। শুরুতেই আমার পরিবার থেকে হালকা হালকা বাধা থাকতো। বাধা থাকা সত্ত্বেও আমি ব্র্যাকের 2005 সাল থেকে এই প্রশিক্ষণগুলো নিতেছি। 5টা লোকের সাথে মিশতেছি, কথা বলতেছি, মানুষের একটা সমস্যা হইলে কোনো কিছু বলে সেটা সমাধান করতে পারতেছি, না পারলে দেখতে দিচ্ছি আমি পারতেছি না, অমুক জায়গায় চলো, অমুক জায়গায় গেলে হলে সমস্যাটা সমাধান হবে। পেশার ব্যাপারটা আমার খালা আসতেছে, আমার ফুফু আসতেছে, আমার বোন আসতেছে, এই বাড়িটার আসতেছে, আচ্ছা খুব ভালো লাগে, বিরক্ত লাগে। স্বাস্থ্য সেবিকা হওয়ার ফলে আমার মনে হচ্ছে যে আমি সমাজেরও সেবা করছি, আমার দেশেরও সেবা করছি। তা আমি একা একা ভাবি যদি আমি ব্র্যাকের সাথে জড়িত না হতাম, এই আনন্দগুলো পাইতাম না, মানুষের বিপদে যায় সাহায্য করতে পারতাম না, আর এরকম একটা নাম ডাকতে পারতাম না। আমার বাড়িতে লেখা স্বাস্থ্য সেবিকা বাড়ি, যে কোনো লোক এখান থেকে যায় যেগুলো যায় সবাই পড়তে যায় স্বাস্থ্য সেবিকার বাড়ি, এখানে ডায়াবেটিস পরীক্ষা করা হবে। আমার অনেক ভালো লাগে এই জিনিসগুলো। রাস্তা দিয়ে হাঁটলো অনেকে ডাকে, এই ম্যাডাম ডাক্তার ম্যাডাম, এই আমার আয়রন লাগবে, এই আমার ক্যালসিয়াম লাগবে, আমার খুব ভালো লাগবে। টাকা বিষয় না, আমি যতদিন আল্লাহ পাক আমার বাঁচিয়ে রাখবে দুনিয়ার উপরে ব্র্যাকের সাথে জড়িত।
So this is the story of a proud Shastra Sevika. So thank you for patience here.
Thank you, Dr. Murshida, for such a wonderful and insightful presentation. I think we were noting a lot of things that we can learn from the BRAC's experience. And we have we're queuing your questions, we're tracking your questions. I've seen a lot of questions directed to Dr. Murshida in the chat box. So we will have a Q&A session after the two presenters. So I would like to call up on our next panelist. Our next panelist is Dr. Mirgesa from Ethiopia. So over to you, Dr. Mirgesa.
So thank you, Dr. Freyot. Indeed, good afternoon, good evening, good morning, everyone, wherever you are. Yeah, I'm just trying to find my, okay, let me just, sorry. First of all, my appreciation to the International Institute for Primary Healthcare for organizing this webinar, which is very, very important in view of the fact that this is an interesting area for Ethiopia, and of course an area that we have all been sort of struggling with, urban hills. I hope you can see these slides, right? Is this slide visible? Sorry.
Yes, you can proceed.
Very good.
Yes.
Very good. Very good. So, thank you again. This is an interesting session, of course, for various reasons. I'll be talking about the responses to urban health challenges and experiences and lessons from Ethiopia. By way of disclaimer, this presentation is coming from experiences that we've drawn from the USAID supported Urban Health Extension project that was supported through JSI Urban Health Extension project that we have partnered as a School of Public Health partner with. And of course, the exhibits that are presented here in different sections of this presentation are being drawn from that, and wherever relevant acknowledgement was being made. And of course, my personal experience as someone who have been involved in the Ethiopian Urban Health Program is also reflected in this presentation. Three most important areas that I'll be really focusing on are laying the foundation for the context and realities that we are in. And I'm speaking to Ethiopia, and of course, because of the fact that this is really critical public health area of concern. And secondly, what are the experiences that we have drawn from the interventions in Ethiopia over the last few years, and what is it that we suggest looking forward. And of course, my former speaker have highlighted the fact that urban health and the urbanization is obviously a global occurrence. It's a fast evolving way of life across the world. And as you can see, probably it has taken a number of years, in terms of increase. If you really look at the time between 1500 to 1900, the growth of urbanization is really negligible, as it is clear. But from 1900 to the time we are in now, you can see the leap. It's really progressing quite unprecedented. And by 2050, as it was already mentioned previously, the world is going to be more urban. The time, as you can see, 20 2010 is like an important time when the trajectory of urbanization has actually shown a critical landmark where, for the first time in the history of humankind, urban residents have surpassed the rural residents. And that's also the reason why we are saying by 2050, 66% of the world population is going to live in urban setting. And for Africa, which is, of course, least urbanized as compared to the rest of the world, by 2050, again, 56% of the population are believed to reside in urban setting. For Ethiopia, which as compared to several other African countries, is really least urbanized, with about 17-18% of the population now, based on existing evidence, are residing in urban centers. Around 38% are going to be residents of urban settings by 2050. So in the next, less than 30 years, we are going to really more than double in terms of the number of population residing in urban centers. So urbanization basically is considered as a social entity. It's an opportunity at times, but it's also a threat for health, as we see. Obviously, as an entity with opportunity, there are possible, better economic and social transformation in terms of education, life expectancy, of course, access to services, and opportunity for participation, better living conditions, food security, and so on and so forth. These are actually anonymous kind of evidences available about urbanization. But the most important points are, yes, these are urban centers are relatively better in terms of economic state, perhaps in terms of nutrition, perhaps in terms of resources. There are talented, skillful persons, individuals, better technologies, improved housing, sanitation, and so on and so forth in urban centers. And of course, employment opportunities are considered to be better. And that's also an important factor that sort of draw the attention of people who are coming, flocking to urban centers. Yeah, I mean, in view of that, then urbanization is becoming a predominant mode of living, attracting more people, and there is obvious trend of inequities across a wide range of societies in urban settings, and some of the major kind of issues of concern because of these inequities in urban centers have to do with nutrition, poor nutrition, of course, pollution-related health conditions, and communicable diseases. As we all understand, emerging, re-emerging infections also affecting urban settings. A good example, of course, is the COVID pandemic, as we see wherever in the world, including ours. The urban settings are the most affected settings. So if we have to really characterize urbanization as a way of life with multiple challenges to residents, these are the different kind of realities as we see. I mean, yes, of course, in migration, yes, we know there are resources, but there are diversities in urban settings, and of course, injuries, accidents in connection to road traffic, slum settings, overcrowding, poor sewages and waste disposal, poor housing, security, unemployment, these are kind of, characteristics. I was just trying to play around with these ones, looking into how those ones are basically, aligned with the trajectory of urban settings. These are issues that we see as we actually zoom in to understand urban settings. So it's always important to look into those different variables, and play around with those variables and the implication of it when it comes to problems, including health problems in urban settings. So that being the case, general kind of realities on ground when it comes to urban, be it in Ethiopia or elsewhere, or in Bangladesh, or in the States. Now, looking into urban health extension program from Ethiopian perspective is very important. And of course, one of the studies that USAID commissioned on urban health extension program back in 2011-12 was 12-13 rather, was looking into urban health extension program, as well as urban health extension workers. And I was involved in that, and what was very, very impressive with the fact that the urban health extension program itself was drawn basically from the rural health extension program, which has come first, which was introduced earlier, and therefore it was copy pasted in a way in terms of program, including the health extension package itself. However, what was different was the urban health extension workers are instead professionals who have diploma level training, most of them clinical nurses, and they were actually recruited as women, female, clinical nurses. They were given training and deployed in urban settings. Now, just a bit of highlight on that. It was very interesting to note that there was challenges in that, because these are clinical nurses who aspire to be clinicians, who aspire to work within health facilities, but they were instead working at community level, and they were community nurses instead. I mean, despite the fact that they were trained as clinical nurses, that was a big challenge. And of course, one of the major kind of concern was where are they going to be based, in the community or in the health centers within the city of Addis Ababa, Daredawa, Jimma, Bahar Dar, and so on and so forth. So this was one of the most important problem. But reality on ground is, yes, they were there and they were supposed to provide such services. And secondly, urban centers, unlike other African countries and across the globe, the slum settings in Addis Ababa, for instance, are not concentrated in specific areas. They are everywhere. I mean, you find high-rising buildings, and then next to it, you find slum settings. And therefore, those health extension professionals are providing, their services at household level to all those settings. And some of those people are professionals, and they find it very difficult, awkward, actually, talking to these guys, to these, young clinical nurses, asking them about sewerage, toilets, and so on and so forth. So as a result, it was challenging at that stage to see them actually, contributing as much. But there are recent studies that show about three-fifths of this is just 2020 study from urban settings on urban health extension program that show 3/5 of the respondents were not really utilizing. Even now, I was talking about 2012, 2013, but now 2020, that the thing hasn't really changed enough. Because as I said, these health extension workers are expected to focus on hygiene, environmental health, family health, disease prevention and control, injury prevention and control, which are basically part and parcel, of course, part and parcel of the health extension package, including awareness creation. Now, the point is urban characterized by these ones, or should we actually consider urban settings and urban residents with different kind of health profiles, health epidemiologies for that matter, which are of concern for urban residents? That was actually one of the issue that we have actually identified at that stage. And obviously, the wider disparities in terms of knowledge, behaviors among urban health population was not really given as much attention, unfortunately, and there was evident lack of resources. As I said, the resource that was given was from USAID, and if USAID or other development partners are not providing those resources, then where is it? I mean, where is it? Does government have really, allocated resources for urban health, other than actually what is coming through vertical program? Was one of the most important element. And obviously, urban health is not health. Urban health is more than health, because it has to do with water and sewerage authority. It has to do with road authority. It has to do with urban agriculture. It has to do with other sectors. And therefore, how do we link and collaborate, integrate, programs at that level was one of the major issue. And of course, as I said earlier, the failure to address more and major concerns at urban settings, such as non-communicable diseases, hypertension, diabetes, cancer, and so on and so forth. And of course, communicable diseases, maternal and child health, of course, injury control and prevention are critical areas of concern that didn't really come out quite strongly in the health extension packages of that time, although we can see now within our HSTP2, we are having those ones revised, at least in general, although I don't know, if that is being taken care of for urban settings. And the linkages between sectors, obviously, as I said, was a critical concern, and clarity, lack of clarity in terms of guidance to outreach at community level. We may assume that urban is urban, but urban is not urban. There are some urban settings that are far less, served in terms of services as compared even to far places in rural settings. So how do we actually organize outreach services to those settings remains unclear for that matter. So yeah, I mean, because of those reasons, and because despite the fact that we are saying that, urban has more opportunities, urban settings have more resources, the urbanization obviously failed to also meet the demands of the community in terms of jobs, in terms of infrastructure, and in terms of housing. Just to pick on one good example from World Bank report, and from urban employment and employment survey of 2003, which is very far as compared to World Bank resource. There are very good portion of urbanites that are not employed, and there are people who are really looking for jobs. And based on available evidence, we are understanding that despite continued in-migration from rural areas, most urbanites in Addis Ababa, for instance, are engaged in an informal sector. In terms of infrastructure development, one of the most important issue is access to services, issues related to crime, safety, and security, and social segregation, alienation, and so on and so forth. But it is quite clear that the infrastructural development has actually opened up opportunities for those issues, including access, thereby making residents to become more vulnerable to crimes, to lack of services, segregation for that matter, and alienation. And the speed at which urban, in fact, in settings like ours, is expanding and is basically compromising service delivery, compromising availability of water, compromising sanitation services for that matter. And as we know, we are now expanding to the fringe. That's making us even weaker when it comes to availing those services. As you can see on the right-hand side, these are waste, of course, including plastic waste. And what we see is, obviously, this is not unique to specific areas, but this is the case in every village within Addis Ababa. And therefore, the more you expand, the more it becomes even worse, actually having this kind of situation. With housing constructions and expansions within Addis Ababa and condos 40, 60, 20, 80, we have seen that the family structure have basically suffered a lot, where we know from our sociological studies that we are always having extended nuclear families, and of course in urban settings we are having our nuclear family. But now that nuclear family has obviously transcended to non-marital cohabitation and single kind of family environment, and where people are also having structures, the support mechanisms that were there that was broken. So one of the resident was talking to a Reuters journalist that I miss my friends, my social life, my work, and I have a nice house but no income. So as you can see, with expansion of housing, sometimes what is missing is there is lack of appropriate integration of that housing scheme to service delivery, employment opportunity, and so on and so forth. So the fact that government's failure to regulate slum areas, dwellers are taking collective action. Yes,
Dr. Mirgesa, sorry, we're running. We also have another presenter, and we have 20 minutes remaining. So this is just to indicate the time. Okay.
Sure, no problem. Those slum areas are again expanding. If we are not controlling those slum areas, those slum areas are also expanding to those new settlement areas. So that are the realities as we see. As I said, we are seeing slum areas alongside high-rising buildings, and therefore we are seeing the realities on ground, where we are finding very difficult to provide more focused kind of health services in those urban settings. So what are the experiences that we have now with the USAID project? What we've sort of seen was we have actually agreed. We have agreed with the JSI and USAID and the Ministry of Health to have a better health outcomes for Ethiopia's urban health population. But we have to have a common kind of roadmap with shared values, transparency, mutual responsibility, and mutual learning, where measurements are clear. And therefore, the Federal Ministry of Health have provided us with policies and strategies, while JSI have clear kind of program implementation role. and the School of Public Health generates evidence for that. So what did we do? For the School of Public Health, we have been involved in research and development where we have looked into the dynamics of urban health demands for service and utilization, where we have carried out a number of a number of studies related to maternal health service utilization in urban slums. Very interestingly, we found out that maternal health service utilization in certain settings in Addis Ababa are far, far less than rural areas. So aggregation of data is one of the major problems. Vulnerability to HIV infection in places and persons in urban settings are most affected, and the vulnerability has been missing. So those are kind of studies that we have generated as evidence, and most of those are actually published. Urban health development centers, we have established an evidence compilation and sharing center, a center where media engagement could take place, where multi-sectoral engagement through think tank could as well be established. So as you can see, the Dean and JSI, and of course, Dr. Zufan, who is the director of Health Extension Program at the ministry then, has actually inaugurated the center within the School of Public Health, as you can see that. And this center has played an important role, not only organizing those researches, but also advocating. We have had a brown bag, lunch meeting with media professionals from all walks of life, private, public. We have been organizing seminars and think tank groups that is composed of health sector, water, industry, and different sectors together to actually advise the government on that. And we have been also providing technical support to the implementing partners, including JSI, on urban health planning intervention, supportive supervision, where policy program evidence were being actually strengthened, and policy briefs were written. So one other important element that we've seen, this is also one of the research outcome, is addressing societal factor is neither easy or sole solution for improved urban health, because it's not just societal factor, it's about economic factor, it's about slum setting, which has to do with urban housing and so on and so forth. So these are also important elements that has come out as critical elements. So by way of concluding, so one of the most important things is, what do we mean by urbanization? What do we mean by urban health? What are the patterns that are involved in this is critical. Obviously, everyone is not sharing the same understanding. We have Ethiopian Demographic and Health Survey, and always we compare rural urban, but urban is not urban. Urban data has to be disaggregated. And of course, for that, we have to have disaggregated data generation mechanisms, whereby we can talk about urban specific data from every sector, every village, and so on and so forth. The other important element is, as we said, urban is not the health sector's responsibility as such. I know health in all policy is an important indication, but the synergy between the sectors with clear kind of line of accountability is very important. Otherwise, as we have seen, water is not available, but housing is being provided by another sector, and then health sectors are actually taking responsibility for what happens in consequence. We have to have demonstration projects like BRAC, which is very important, where we have to have clear kind of methods, tools, experiences being documented in order for us to learn from that kind of lesson. We have tried to actually organize a project that is meant for specific areas like Sabatanya, which is more slum area, so that we can draw some lessons for Ethiopian cities. But unfortunately, because of funding, we couldn't really move that forward. Tracking progress, of course, that could actually come from that one, but tracking progress in terms of risks, outcomes in relation to sustainable development goal is quite critical elements. Obviously, as I said, the policy development and implementation aspect requires proper attention in terms of occupational safety, urban pollution, immigration from rural to urban, health equity, and the social capital development. And we have to also look into structures, local structures such as and so on and so forth, that have been, unfortunately neglected when we expand with new housing schemes that we are having here. So I hope that would bit of shed some light on the realities on ground here. And thank you so much for the time. Thank you.
Thank you, Dr. Mirgesa. Thank you for this wonderful presentation. I would like to proceed to the next panelist without further ado. So I would like to welcome Mrs. Dennis from USA to share her experience.
Yes, good morning. I bring you greetings from New England, the eastern coast of the United States. I'm going to spend the remainder of my time talking about the characteristics of community health workers in U.S. urban primary care. So I am not a primary care provider, a doctor, an APRN. I would like to recontextualize this conversation from the perspective of a community health worker. And I thank you in advance for your time. It is very important to frame this conversation in the United States in the context of over 400 years of colonialism, 250 years of chattel slavery of enslaved Africans brought from the African continent across the diaspora and into the United States. It is impossible to separate a conversation about primary care, health and well-being in health status and outcomes without this context. And the context of community health workers and our roles in primary care is intricately tied to this colonialist history and the history of community organizing and power to ensure the survival of populations. I've provided a very brief history here of the impact of relocations, the trail of tears, written and broken treaties and reservations across over 538 federally recognized tribal nations who were guaranteed access to healthcare among a variety of other services, but yet across the United States, across these many hundreds of years, continue to have lower life expectancy and higher rates of disease and death across almost every indicator. We can see the early impacts of urbanization in the landmark Philadelphia study of W.E.B. Du Bois, who in 1899 observed the impact on enslaved Africans migrating north to find work in urban areas and factories in 1899 and recognized the impact of structural racism on the health of the descendants of slaves in their income, the use of alcohol, the spread of socially transmitted and sexually transmitted diseases, and rates of employment. Across the history of the United States, we see that there have been laws to try and mitigate the impacts of poverty, the impacts of structural racism across our Medicare and Medicaid programs. We have seen federal agencies be born out of studies on the impact of persistent health disparities born out of structural racism for Black and other minority populations. We have seen foundations like the Robert Wood Johnson Foundation engage primary care providers who wrestled with and were frustrated with the impact of the social determinants of health, the social drivers of well-being on their ability to achieve primary healthcare goals, saying that it was impossible for them to address chronic asthma, pediatric asthma, without simultaneously addressing safe and affordable housing, addressing mold, rats and roaches in homes. Their desire as primary care providers to want to write prescriptions for nutritious food or safe housing and their inability to do so. And of course, we look to our current state where nearly 30 million Americans today have no form of healthcare coverage, public or private, and where 38 million are uninsured or underinsured. So this brief history is important for us to understand the context of primary care today. As we continued as a country to have the migration of a variety of communities, as our indigenous tribal nations were striving to make a life and a living on reservations across our country, as we continued to experience urbanization and the influx of refugee and immigrant populations, we see these challenges increase in the context of a country that was born out of colonialism and chattel slavery and the impact of structural racism. It is within this context that the community health worker model came to being in the United States. And so don't labor to read this slide, there are too many words on it. But the point here is that it is these very diverse communities and populations, indigenous, enslaved Africans, and those who came to the United States across our Pacific Islands, Asian American, Native Hawaiian, through Central and South America, Mexico, and across the African diaspora, where we find the origins of these CHW models. For hundreds of years, communities have come together to respond to the impact of structural racism on their access to medical care, behavioral health services, and those social drivers of well-being, income, safe housing, literacy, etc. Community health workers in the United States today do have a definition. CHW is an umbrella term that includes our promotoras, our community health representatives, who are those CHWs from over 530 tribal nations, but we have more than 50 job titles. We are frontline public health workers, and central to our definition is our trust, our shared life experience with the communities where we live and serve. It is this shared life experience, the experience of those barriers of structural racism, that allows us to build bridges from individuals, families, and communities who are striving to achieve health and well-being to link to those health, social, behavioral health services across the community and systems and sectors that can improve health and well-being. It is important to note that there is no national or state level community health worker program in the United States. And so community health worker services are not intricately and consistently tied to primary care. Quickly, I just want to voice over some of the environment where CHWs and primary care operate today. As you look at this image, you'll see everything in blue represents a medically underserved community. This can be a community by zip code or region across the United States. It is almost representative of the entire United States, where we find low and challenging access to primary care, to dental services, to behavioral health services. Economics, racism, identity, stigma continue to result in the denial of care, the provision of substandard care, physical and verbal abuse, or foregone care. And so in these medically underserved areas, and I'll show in the next couple of slides, we see persistent disparity in health status and health outcome. Quickly, I'm just going to voice over some sort of modern statistics across the US. We have had, over the last several decades, rising overdose deaths from opioids. As early as the 1960s, we began to experience a rise in heroin use in the United States, which has persisted today and now includes prescription opioids and fentanyl and others. And we see that within our most populated cities, as we compare these two graphics, we have the same sort of increase in our overdose deaths. As we look at other ways to compare health status and outcomes in the United States, we see that the rates of food insecurity across our US, our middle states, and across the southern states, what we would say is below the Mason-Dixon line, are aligned with gun violence deaths across the United States. And while the US has the worst gun violence death rates of all countries in the US, we see concentrations in some of the same places where we have rates of food insecurity. We know one of the primary drivers of food insecurity is poverty and economics. And so we begin to understand the need for primary care to address the social drivers of well-being if we intend to ameliorate or prevent these gun violence deaths. A few final examples. We can also look at the state of perinatal mortality and compare that to rates of poverty in the United States. And again, while we see hotspots across the country of poverty, we begin to see concentrations in those same areas where we saw chattel slavery, in some of those same areas where we see rates of gun violence death, in some of those same areas where we see food insecurity, we see perinatal deaths and poverty. And so community health workers strive to build bridges between the various systems and sectors and services, public and private, that are impacted by structural racism and modern day challenges of access in these medically underserved communities across the United States. We are delivering diapers. We are helping people enroll in health insurance. We are helping to distribute masks and food. We are helping to shift policy and impact policy across the United States. Community health workers today in an urban context are a precarious workforce. We are disproportionately female. We are disproportionately persons of color. And again, we have that shared lived experience of a colonialist context and a context within which structural racism impacts access, quality, and outcomes of health. We serve those communities and are operating in programs that have very inconsistent funding, usually grant-based, with some growing sustainability from public and private payers. But we provide short-term relief to these marginalized communities that I've described earlier. We are working in under-resourced communities, urban and rural. And we are striving to, again, bridge those silos and sectors, provide care coordination, build community capacity, and we consistently advocate upstream for policy and system change through research and community engagement. I just want to give you a few bits of data from our National Association of Community Health Workers that was founded in April 2019. I'll talk more about that later. It is important that we understand from the thousands of members that we have today, we are working again in a variety of different settings. We are community organizers and outreach workers. We are working in our federally qualified, largely publicly funded health centers and primary care offices. We are providing health education, care coordination, conducting home visiting across urban and rural centers. We're doing a variety of chronic disease research. We're helping enroll people in public and private insurance. And we are helping people navigate very complex and siloed systems that go between primary care, specialty care, hospitals and clinics. Our expertise is again varied, and so I won't labor to describe that, but again, helping to address a variety of gender-specific health issues, maternal and child health, mental and behavioral health, as well as upstream issues of housing, basic needs, and immigration. Within our membership, it is the case, and it is the case nationally, that all community health workers are not formally employed. Many of us are still volunteers. We are paid in short-term grants or what we call honorariums or gift cards. But of those who are employed, 62% of those are still working in community-based organizations with fewer concentrations working in hospital and health systems or federally qualified health centers. Quickly, I'll just say that there are over 6 decades of evidence of community health worker effectiveness. And so on the right hand of the slide, you'll see that CHWs are working to address a variety of different disparities in primary care, diabetes, working to improve the patient-centeredness of care, helping with interventions around maternal and child health or with vulnerable populations, a variety of mental health issues. One of our federal agencies, the Patient-Centered Outcomes and Research Institute, has for the last 10 years conducted research on over 70 different interventions that impact, again, chronic disease, maternal and child health, infectious disease, and that all embed community health worker programs, but CHWs continue to lag in a consistent and sustainable funding source or even orientation to primary care. We continue to address that as a barrier. CHWs have come together to define their own roles and competencies. And so here I'll just say, I would recommend you review the C3 project, which was developed, these roles and competencies that you see before you, with hundreds of CHWs, promotores, and community health representatives on tribal nations to articulate for the United States our roles and competencies across systems and sectors. Inequity in the United States, as we've already sort of gone through this journey for many hundred years, continue to persist in the midst of the COVID-19 pandemic, where 100 million people living in the US were living at least 200% below the federal poverty level. 1 in 5 people with health insurance were experiencing medical debt or problems paying for medical care, and 6 out of every 10 people in the United States were living with at least one chronic disease. A variety of services were provided by CHWs during the pandemic, and many of these were some of the same services that we were providing to, again, address the siloed sectors that impact primary care, mental health, and the social determinants. So I won't sort of, for time's sake, continue on with this list here. What I will say is that during the pandemic and beyond, CHWs continue to address social justice issues. There was an increased rise of violence, community violence against our Asian American, Pacific Islander, and Asian presenting Native Hawaiian community members across the United States during COVID-19, and CHWs continue to address that issue. As well, during the COVID-19 pandemic, we have had to expand our service delivery, our community engagement, our advocacy to address historic and issues and systemic racism concerning the mistrust around emergency use vaccinations. It is important for us to end where we started, which is for people to achieve health and well-being, we must tie primary care to the social drivers of well-being, particularly in the United States, who has experienced colonialism and 250 years of chattel slavery that impact people's ability to access primary care, and those socioeconomic factors, physical factors that have an impact of up to 80% of what actually impacts people's health and well-being, education, job status, the supports that families and communities receive, income, and community safety and well-being. So the National Association was founded in April 2019 to unify this very diverse workforce across ethnicity, across geography, across experience and sector. We are survivors of chronic disease and HIV/AIDS. We have experienced homelessness and cancer. We are those who were formerly incarcerated and now are coming back into the community. We are diverse promotores, community health representatives across geography, sector, ethnicity, and experience. And we are coming together to support our communities to achieve health equity and social justice. We are partners in primary care, but we are rooted in the community, in advocacy, and in community capacity building. And so the National Association has come together with CHWs and allies of primary care and public health, behavioral health, and research across the country to articulate policies that will protect our workforce, that will respect our workforce, and that will partner with our workforce to achieve health and well-being for all communities. Thank you so much for your time.
Thank you, Mrs. Dennis, for this wonderful presentation. I've seen our participants asking questions through the chat, and some of our panelists were responding to the questions directly in the chat box. I know we're a little bit behind time. We were supposed to finish top of the hour, but we will take a few minutes to at least give our panelists to respond to one question each, because I saw most of them were requested. So Dr. Morshida, you have already identified the one that you want to respond live. So I will go to you to respond to that question.
Oh, sorry, can you repeat the question again? I forgot.
You have selected from the questions in the chat box that the one that you want to address live.
I guess I lost it. Can you see it? Because I have answered it already, I guess. But that's why it's not shown here.
Oh, that's why, because I saw one question being raised there. So I think we will come back to you after identifying the questions. And for the questions raised to our panelist from Ethiopia, Dr. Mirgesa had to drop off because of his engagement in another meeting. So we have Fikrom Gebramedin from Addis Ababa Regional Health Bureau, who is the primary health care and health extension program lead at the region. And I'm going to direct this question to you, Fikrom. So the question is, what is the recommendation on practical revitalization of piloted urban health extension program in Ethiopia to have that health literacy transformed community?
Okay, thank you so much. Regarding the urban population health literacy, the best recommendation and currently the inaction way of service delivery is working with the urban family health team program or the primary health care reform program. So within this, we do have family health team approaches in health centers. In the urban health program, there are more than we have health centers who serve more than 40,000 population. So in each health center, we do have 5 to 8 family health teams. Each family health teams do have 8 up to 12 health professionals, including the urban health extension professionals, which are mentioned previously by Dr. Mirgisa. So using the urban family health team program, or the urban family health teams in the health centers, which are working in the community aligned with the health extension program. That's what we are currently working, or the after the urban primary health care reform has been implementing in cities or towns in Ethiopia. Thank you so much.
Thank you, Fikro. So, Dr. Morshida, I have one question. How is BRAC or Bangladesh addressing the issue of multi-sectorial engagement in terms of urban health? Because that has been identified as one critical area, and but most countries are lagging behind, including ours. So just wanted to hear from your end what Bangladesh has done so far, or what are you working on in that regard?
Yeah, I think one of the best opportunity in Bangladesh to work as an NGO is that Bangladesh government is very supportive in welcoming all the partners. Different stakeholders are working hand in hand in the health system. That it's a if you compare with neighboring countries, you won't see this NGO sector has been flourishing the way it's happening in Bangladesh. So government is very welcoming in terms of giving us opportunity to filling the gaps in the health system, and working together. But the system of reported accountability was not developed that much, but now government has is working on that, and there is a regular meeting with all the stakeholders on how to improve that. But I would like to answer a very critical question, and this is basically two, that how we are institutionalized community health workers and their sustainability plan. So this is really a great question, because over the time when the aspiration of people will change. And now, like 40 years ago, when we started the community health worker program, it's not relevant now. So we have been changing, but it has to be changed based on the context of technology and other things. So they have to be relevant compared to based on the requirement of the population, and we are connecting them with the local community healthcare system, government healthcare system. So we have 14,000 community clinics. So we have an MOU with the community clinic where we will support them to develop their infrastructure and also the whole system, and where we have engaged our community health workers in 6 districts. So that is in a pilot mode. So if it works well, then government will allow us to institutionalize our health workers there. So in future, this health worker can be a part of the government system. So that is one thing, that is one part of sustainability. And the other thing is that these health workers, they are self-sustained. I already told you that 43,000 of them are self-sustained. We don't pay them. So with the help of technology, they are more connected with the other improved services, and that is making them more reliable and more sustainable nowadays. And the second thing is that the other sort of sustainability. So we are thinking about also cross subsidization by social enterprise development, and also community, also healthcare financing, like micro health insurance system development. So that is another part of story, but that thing is also happening in Bangladesh. So our primary healthcare system is evolving around both in urban and rural areas, and we are ready to like take the challenge of this scarcity of the funding that we have to face due to our status of middle income country, being a middle income country. Thank you.
Thank you, Doctor. So our last question is directed to Ms. Danis, and the question is, can you just indicate two major policy changes that you would like to see in relation to community health workers?
Oh, yes, thank you so much for the question. And I'll refer to the policy document because I believe the slides will be shared and you'll be able to click on that and read that more fully. Community health workers lack a professional identity and sustainability here in the United States. And sustainability is quite holistic. It includes acknowledgement of our rootedness in community. It includes an acknowledgement of broad CHW roles, not just as deliverers of service, but as upstream transformers of systems and sectors and policies. And so community health workers are coming together now to address systemic and structural racism and how it impacts the social drivers of well-being, because those are what comprises up to 80% of what impacts a person's health. It is not a medical treatment, a prescription, or a healthcare service, but it is the social drivers of well-being. So addressing structural racism across systems, silos, and sectors in the United States will help to move the needle and redistribute funds equitably so that we can increase access to healthcare services, ensure universal healthcare coverage, and begin to integrate these services and sectors so that we can achieve health and well-being.
Thank you so much, Ms. Dennis. I think we're almost finishing our first series webinar. Thank you, everyone, all the participants and panelists and our technical people at the back end trying to organize and coordinate this. I would like to thank you all on behalf of the Institute, and I would also like to say that this gives a lot of insight in terms of looking at urban health extension program from different perspectives. So we're looking at different contexts and we're selecting different thematic areas in terms of urban primary health care rather than seeing it, as one generic thing, and that will be very important in the subsequent sessions. So I would like to call upon everyone to stay tuned for the upcoming webinar that we will have on July 29. Please continue attending this webinar. For those who are participating from Ethiopia, please note that this will have CU points once you finish the series and get certified. And our colleagues engaging outside of Ethiopia, please continue your engagement with us. Also visit our website to see more upcoming events like trainings and any other events that we host at the Institute. I would also like to thank our colleagues from Johns Hopkins University, Dr. Rajani, for coordinating and leading this entire process. So my apologies as well for keeping you almost 60 minutes from the initial schedule. So have a nice day, evening, morning, and thank you. Thank you, everyone. Bye.
Thank you.
Thank you.